Hello, I'm Ira Bedzow, and this is The Good Life, a show that talks about all aspects of human flourishing, from physical and mental health to social and spiritual well-being. I want to thank our sponsors for this show, the Restoring Religious Freedom Project at Emory Law School, and Shlomo's Restaurant at the base of Aspen Mountain. The topic of today's show is, what does integrated care mean? And I will be speaking with Ross Brooks, who is the Executive Director of Mountain Family Health Centers. Before we begin discussing what integrated health is and how it works, let's break down the issue to give some background and set the stage. Healthcare today has many different specialties and professionals who have different scopes of practice and expertise in delivering specific aspects of care. Yet, just as having too many cooks spoil the broth, too many medical professionals involved in one's care might be detrimental if there's no means for professionals to be able to work together cooperatively and to communicate effectively amongst each other. Integrated care is an approach to healthcare where various professionals work together in a coordinated way so that healthcare is not fragmented. Yet who is included on the healthcare team, how different professionals work together, and how different professions find a common goal creates challenging interprofessional and logistical challenges. With this setting of the stage, let's see how a leader in an integrated care system is able to overcome those challenges. Ross, tell me a little bit about Mountain Family Health Centers. What is its goals and who's its clientele?
Well, thanks, Ira, for having me here today. So Mountain Family Health Centers is a community health center. We started in 1978 in Black Hawk, Colorado on the eastern slope, and really grew in the 90s and 2000s on the western slope of Colorado in Glenwood Springs, Basalt, Rifle, Edwards, and many other communities on the western part of the state. Our goal is to provide integrated medical, dental, and behavioral health care for communities in need across the western slope. And today we've grown to be able to serve about 19,000 folks in our communities, providing that affordable, integrated care across Pitkin County, Garfield County, Eagle County, and Rio Blanco County as well.
You know, so you're the Chief Executive Officer of Mountain Family Health Centers. What does a Chief Executive Officer do, given how many different professions are involved and how many different populations or communities you're working with?
I mainly go to meetings. That's my discernible talent. Answer emails as well. But really my overarching goal and my job is to balance, to make sure that we're providing effective integrated care to the entire community. So we encapsulate what we do under something called the quadruple aim. It was originally conceptualized as the triple aim under the Institute for Healthcare Improvement, and now we call it the quadruple aim, and it really has four simple principles. One is that it's our job to improve the health of the community. So not just to prescribe medicines or to see you for your dental visit or to prescribe you an antipsychotic, but actually to help improve the health of the entire community, beyond just our 19,000 patients, but really everyone in the community. That's our first goal within the quadruple aim. Secondarily, we want to improve the patient experience. So many people don't like going to the doctor, myself included sometimes, and it's our job to improve that experience of care so that people actually have an engaging, dare I say, even wonderful experience with their healthcare provider. Third, we see it as our role to control the total cost of healthcare. So not just the cost of our services at Mountain Family Health Centers, but to reasonably control uncontrollable healthcare spending across the western slope in the state of Colorado and around the United States, so that healthcare can be affordable and accessible to all. And then last, we're really trying to engage and empower a workforce at Mountain Family Health Centers that loves their jobs. There's a really stark stat where about 60% of doctors today tell their kids, don't go into this profession. Become an IT professional, become a writer, do not become a doctor because of the paperwork, the laborious parts of the job, and it's not joyful for almost 2/3 of providers. So we're trying to change that tide to ultimately make healthcare an enjoyable, wonderful experience and profession. So long-winded answers, it's my job to be the curator of those four areas for our community.
No, that sounds like an enormous task.
I'm also a patient too, so I'm the CEO, but I'm a patient of Mountain Family, so I access our own services, and I get my care at Mountain Family as well.
All right, so then you know, you have to tell me both as a CEO and as a patient. It seems to me as healthcare and an integrated care model is not simply additive. How is integrated care, both in terms of its mission and in its practicality, functionally different than just additive care?
I think for most of our history as Mountain Family Health Centers for the last 40 years, And throughout most of the United States, we kind of treat different body parts differently, and we pay for different body parts differently. So we literally pay for mental health, dental health, knees, hearts, physical well-being differently. And so we've bifurcated our system where we're paying for really all healthcare delivery separately. Integrated care says this is a whole human being. This is not a price tag on the ear and the brain and the heart. This is a whole human being. And so integrated care says we're going to pay for that whole human being to help improve their care, to help improve their health, and ultimately to improve their mental and physical well-being. That's what we try to bring to bear at Mountain Family Health Center. So what that means practically is medical doctors working with nurses, working with licensed clinical social workers, behavioral health providers, psychiatrists, dentists, hygienists, working together as a team to serve your needs as a patient. Really integrated care, one-stop shopping within the community health center's four walls.
You know, so this is interesting to me, and I want to ask you if I'm correct or not. So there's a lot of terms out there. One term that I hear often is collaborative care, and at first I would think that collaborative care and integrated care mean the same thing. But as I'm hearing you talk, it seems to me as collaborative care is looking at different specialties and how specialties can work together, where the focus is how do the different specialists talk to each other and either share their business or so forth. Where integrated care, that is secondary, not the primary focus. The primary focus is how do we focus on the patient in all aspects of the patient. That's right. So you need the different specialties, but you need the different specialties because a person is multifaceted, not because their specialties are diverse and distinct.
Yeah, well said. We're what's often called a PCMH, a patient-centered medical home. And we joke that the P sometimes gets hijacked and people think it stands for process, provider, payment, policy, all of these things. No, PCMH stands for a patient-centered medical home. So integrated care really is about the ultimate and total well-being of that human being. Now, the coordination with specialty care, hospitals, faith-based communities, school systems, housing systems, our partners in public health, private practices and public practices. That coordination is a huge part of the integrated care pursuit, but at its base, integrated care is about delivering what's best to the human being when and where they need it.
Wait, so how do you address social needs as primarily in a healthcare system institution or organization?
Great question. So the most brutal answer is we're not that great at it yet today. We have aspirations.
By the way, I'm sorry to interrupt, but I value the integrity of your honesty.
Thank you. For most of our Mountain Family career and within mainstream medicine in the United States, we kind of think you come to me and I will treat you when it works for me Monday through Friday, 8 to 5. If your child gets sick on Saturday night, tough luck, go to the emergency room. Right. I'm looking at this book that we'll talk about a little bit later out in the rural, but when they started community health centers out of the roots of South Africa during the apartheid era South Africa, and as it came to Mississippi and Massachusetts and even our own Denver, Colorado, they're trying to bring medicine to the people, but what they realized really quickly was people actually didn't want medicine. They didn't want traditional healthcare. That was not the top of their list. What was at the top of their list was good jobs, affordable housing, affordable, nutritious food within the community, and to not be discriminated against in their places of work. Healthcare, traditional medicine was like 5 or 6 on there. So a long-winded way to say we've got a lot of work to do to start to influence outside of our 4 walls. I'm proud of the community partners that we have and how we're trying to see ourselves beyond our 4 walls, to work with housing agencies, to work with public health agencies, to work with faith-based communities, to ultimately provide a coordinated system of care, but we got a long way to go until we're there.
Yeah, it's funny. I would say that, looking at integrated care and its focus on the individual, it seems as if it's changing the nature of the conversation, where healthcare today looks at health as an essential good, meaning it's good in and of itself and it's what we should pursue, which is admirable. But integrated care looks at it, and again, correct me if I'm wrong, but more as an instrumental good. We need it, but it's not an end in itself. It only allows us to do all of the things that we can do as human beings.
Yeah.
Right? It's the baseline. It's not the top of the mountain. But when you look at it that way, it's so essential, but it can't be alone. You have to work with your public servants, your civil servants, your faith-based communities. Those people are out there looking at the other aspects of Maslow's hierarchy of needs, if you will.
Yeah, well said. And so where we're at today in maybe the more progressive parts of the healthcare industry, and I mean that big I industry, is we do great work on trying to keep people out of the hospital today. So to get people the primary care they need, to help you not utilize the hospital unnecessarily, to not utilize the emergency room, to try to utilize generic drugs. But we're still asking you to be dependent on the mainstream healthcare system. Over time, if we really get this right, you will need your primary care provider even less. Not just the hospital emergency room, but you will need to come to me even less, because you will have the tools and the resources you need to ultimately live a healthy, happy, productive life. And that's where it takes all of us as healthcare professionals checking our hubris at the door and saying we are not, we joke and sometimes call it the M deity at the end of the day. We are not the M deity. It is our job to facilitate health and well-being in the community.
So what are some of the challenges of working with the community in an integrated health model?
I think from a community perspective, actually, these communities on the Western Slope work pretty darn well together. There's something, I came from Denver before, and I was in Washington, D.C. before that, and what I found in rural communities is people work together because they need each other. Cutthroat competition doesn't cut it in our small rural communities. So people work pretty well together from a community perspective. I think the major challenge is how we pay for healthcare today, because we still pay for body parts differently in a different way. So that really just silos the entire healthcare system instead of rewarding the total well-being and the total health of the community. So as much as we can, we're working on policy issues to try to change the payment structures within the United States healthcare system with health insurers to reward total population health and human being health versus paying something separate for a shoulder or my mental well-being.
Okay, so when you get to paying, this gets complicated for me, and I would love you to talk about it a little bit more. And the one example I'm thinking of is faith-based, but it happens everywhere. So how you pay for things is going to determine who has control, or who sets the agenda. But you need to be paid for, right? So there's going to be a very different payment structure and therefore conversation if, for example, you want to talk about end-of-life care, where you talk with pastors and have them speak about it in their churches, or if you hire those pastors as chaplains and talk about it through the hospital network, right? That payment structure is now also going to affect the comfort of who's having that conversation, who's involved, and who's willing to go to that conversation. Because it's a lot easier to have that conversation in your local community under the auspices of your pastor as your religious mentor than have it as now it's being co-opted by the healthcare system so insurance can pay for those types of quality of care discussions. It just seems creepier, for a lack of a better term. But how do you negotiate that? Because payment is really important.
Who knew healthcare was so complex, right? I think most human beings would rather be cared for in the comfort of their own home or with their trusted faith-based leader or with a peer. That is true most of the time for most families. Most reimbursement systems don't honor that and pay for that today. So I see it as part of our fiduciary responsibility to shift the tables on that, to say if it's really patient-centered care, then maybe the reward should not go to the hospital, should not go to the doctors. Maybe the rewards and the investment really should go to those peer networks or those faith-based networks that serve the needs of the human being. There's this brilliant gentleman from Kenya who at the Aspen Ideas Festival this summer, they do 10 big ideas to change the world. And his big idea was grandmothers. I want to train grandmothers and give them the behavioral health skills they need to talk to their local community and provide behavioral health and counseling in the community. And that would really blow up the mainstream behavioral health system. But it's such a pragmatic way to deliver health care and behavioral health to people and to have a trusted friend or somebody to talk to work through whatever behavioral health issues you have. So I'm fully supportive of shifting those tables. What we're up against in doing that is 1/6 of the economy. And in a massive healthcare industry that is dependent on the current payments structures and systems that are. I'm fully supportive of trying to shift at least 80% of what every dollar we spend in healthcare into a public good, into a public utility that treats the whole human being.
So have you had obstacles, or has there been pushback from the medical professionals, whether it's been professional societies or individual physicians or other medical providers, in terms of, I don't buy this, or I buy it but I'm not incentivized to carry it out? Or forget the community side for a second. From the professional side, what have been some of the obstacles?
I think it's not quite as overt. It's more insidious. But I'm looking back at the book again. So when they started community health centers back in the 60s, Dr. Jack Geiger, very intelligent, Harvard Public Business School, public health school, committed to providing community health. He got kicked out of the American Medical Association for being too progressive, liberal, trying to provide health care to all. And as we look today, our state had Amendment 69 just last year, which wasn't single payer, but it tried to move towards universal health care plus Medicare for all to make sure most people were covered in our state. And those that were primarily opposed to it were major medical and healthcare organizations. So it's hard to change. And people, and myself included, we will sometimes defend something that is siloed and isolated instead of going for what is the greater good.
Well, let me ask you, if it's so hard to change from the provider perspective, is it possible for individuals to integrate their own care, or how would that work? What is the pushback or the alternative?
I think there's multiple alternatives. I think one is for the healthcare industry to just get with it and start providing integrated care for the human being that is patient-focused and less payment-focused. I also think for individuals, myself included, my family, is to take your care into your own hands. So it's my responsibility to pursue my own spiritual well-being, to pursue our own health well-being. And many times that means not needing a primary care provider or the hospital system or other antiquated healthcare systems that don't necessarily serve my own good. So I certainly have responsibility in that. And every one of your viewers and everyone who wants to read this book, it's on us too to take healthcare and health and well-being into our own hands.
Do you think technology can play a role
Yeah.
in integrated? So how would technology play a role? Because a lot of times technology is a tool that might allow for technical things to work better if it's used correctly. But some of the things that we've been talking about, like conversations and so forth, sometimes aren't best done on Facebook. Right?
Right.
So how does technology play that role?
I don't recommend Facebook visits yet, but I think live Skype talking to your provider is a real I do that with my primary care provider. We use our iPhones with each other, and we have many of our conversations just like you and I are having from my office, or you could do it from New York City while he's in his office. I think from a behavioral health perspective, that is sometimes a much more friendly way to deliver behavioral health services to people. Many providers will say, well, I've got to have the hands-on in order to treat this patient, but after the relationship is established, there are great ways to do telemedicine, telepsychiatry, telecare coordination that doesn't require us to be in the same physical space, but we can just actually talk to each other over iPhones or over iPads that are provided at the community level.
Mm-hmm. So are you a physician yourself? Or?
I am not.
So then how did you get into this? Especially now that you're running you're CEO of the Mountain Family Health Centers, and your vision is very well integrated both in terms of the community and knowing the healthcare professional side. How did you become who you are and where you are right now?
Dumb luck. I'm the son of a preacher man, so that gives me my social justice heart, and I'm the grandson of a fairly well-to-do businessman, which gives me a sense of, minimal business savvy. And I worked in Washington, D.C. for 3 years out of college, helping large healthcare systems throw more zeros to the bottom line. I learned a heck of a lot, but that was not meaningful to who I am and to my heart. And I serendipitously found the community health center model in 2002. I started working for a group called the Colorado Community Health Network, and the very first community health center I walked into was in Nederland, Colorado. And I saw a model of care which was not about profiting off the people, but was actually just about delivering the type of care that people needed in the community. And I was hooked right off the bat, and the rest is history. I'm here now trying to fight for equal access to healthcare for all in the community.
So this is something that I'm noticing a lot, where a lot of senior executives in healthcare systems are not themselves physicians. They're either public health or they're lawyers, but they're not traditionally coming from a medical school to a medical professional background. So now it makes me wonder where here, from the clinical side, physicians are losing power, if you will, based on patient-centered care and patient autonomy. From the systems or organizational side, physicians are losing power because the people who are now running these systems are not physicians. How does the professional societies and physicians feel that squeeze on both ends of the healthcare system in terms of, historically, the AMA ran how healthcare was going to look. Today, it looks very different in terms of who is determining where healthcare is going to go.
Yeah. Great question. Not being a physician, I can't tell you necessarily.
You can be like, all right.
What I think we try to honor the knowledge and the humanity of all of our staff, which includes physicians and community health workers, which includes front desk staff and CEOs. And in my mind, honoring a balance therein of the collective team is the best way to deliver integrated care within the community. So that's kind of my short-winded answer on.
Has there been conflicts in terms of, for example, the physician's role traditionally was as a healer, and healer really meant like healer of disease, where nurses' roles were more towards a carer, where they were also healers, but not necessarily healers of disease, but healers of the illness experience. Right? When you look at this integrated model and you recognize that patients, nurses, chaplains, physicians, senior executives all have different understandings or goals of what they think medicine and healthcare is that a conversation that's been having of, okay, how do we get on the same page and complement each other with an E, not an I?
Yep.
Although they can complement each other also. To have that type of unified goal, even if there's so many differences in vision?
Yeah, I think really the movement is called team-based care, which is supportive of an integrated care system with the patient at the center. Is there conflict in making that evolution? Absolutely. But the way we look at it is advanced primary care practice and true integrated care requires a team that is ultimately encircled around the patient to serve the patient's best needs. So there's a lot of in-the-weeds operational changes that we're going through right now to ultimately have that team serve the best needs of the patient. Have we totally been able to get rid of hierarchy between MDs and RNs and LCSWs and psychiatrists and dentists and dental hygienists? No. But team-based care model is the right path to get us there.
And just, do you think that the role of government, and I don't actually mean necessarily only public health, but the role of legislation will serve the purposes, or is this more of a, regardless of legislation, we need to figure this out as a market and a business model? Legislation can only take us so far. Like, where do you see the government involved in this?
Great question. I probably don't have time to give you my entire answer, so just cut me off.
With pleasure.
I think it's a balance. I would go back to, I truly believe that if we treated health and well-being as 80% public good, I could live with a 20% free market, allow the market to have its hand and to promote innovation and to move things forward. I don't think we're there as a country today, and so I do think it requires government intervention to try to get to at least 80% public good. In regards to which legislation is going to do that, Congress hasn't killed us this week, so I'm happy about that. But this movement towards public good seems to come up against really fierce opposition every single time it comes up. So right now we have Medicare for All from Sanders. We have Medicare X from one of our state senators here in Colorado, from Bennett, and Kane out of Virginia. And then conversely, we've had 3 different efforts to repeal and replace Obamacare, the Affordable Care Act, and now it's just starting to get gut kind of insidiously through the tax reform process. So we could spend an entire show talking about potential policy solutions. I do believe there's a role for government to help move health towards more of a public good in our country.
Well, listen, Ross, I want to thank you so much for having this conversation with me. I think this is an important start to a conversation. Well, I'm sure you've been having it for a lot longer than we've just been having it here. But what I mean is, this conversation needs to be in medical schools. It needs to be in interprofessional education. It needs to be in public discourse. People need to recognize that integrated health is not only about clinical practice or who's paying for things, but recognizing health as a means to a individual and social end, as much as we need to be physically healthy. Physical health is importantly and integrated, tied integratively to our community health, our mental health, our spiritual health, because we focus on the whole person. And only when we focus on the whole person will we be able to reach that type of human flourishing. So no, thank you.
My pleasure.
So we have reached the part of our show where I recommend a book that can provide greater insight into the topic that we've been discussing. This week, I recommend Out in the Rural, a Mississippi Health Center and its War on Poverty by Thomas J. Ward Jr., with an introduction by Jack Geiger. This book tells the story of the Tufts Delta Health Center in Mound Bayou, Mississippi, and the Columbia Point Health Center in Boston, which were created as part of Lyndon Johnson's War on Poverty in the 1960s. Both centers were founded by Dr. Jack Geiger, known as the father of community medicine, and members of the Medical Committee on Human Rights, which consisted of a group of physicians who were part of the civil rights movement. The idea behind the centers and the approach to healthcare that they promote was introduced to Geiger when he studied under Dr. Sidney Clark in South Africa, who had developed community-based health centers, which Geiger then brought to the United States. This book teaches two valuable lessons. First, in terms of concept, it teaches the valuable lesson that healthcare is more than about simply medicine. It is about improving a person's and a community's basic necessities, as well as giving people the social and political abilities to live healthy lives, which includes providing not only nutrition and medical treatment, but also education and opportunities to develop economically. Second, in terms of implementation, it teaches that to improve healthcare, we mustn't think of health as one big challenge to tackle, but rather as a combination of many different challenges, each of which should be approached on its own terms, as well as in conjunction with the ultimate goal of creating a healthier society. Out in the Rural is a true and valuable story of how to build a healthier tomorrow by focusing on all aspects of human flourishing in an integrated way. We will close each show with the maxim that we hope will provide a simple takeaway that keeps you mindful of the ideas discussed. This week, the maxim is, not enough for more care to be added. Health and welfare must be integrated. We hope that with this show, you've come a little closer to achieving the good life.